casting that they don't really use anymore, right? But that's what you have to use because the plaster contours nicely to your palm. The fiberglass is too rigid and it doesn't contour to your hand. But, so the purpose of this is to cast what moves well and leave out what doesn't move. So the doctor will think you're crazy when you have a patient with stiffness and you want to put them in a cast, right? So you have to be able to explain what you're trying to accomplish. So you make a cast, and before you make a cast, you need to make sure you have a cast saw, because you have to take it off, right? You have to have a cast saw if you're going to do this, because you can't just cut this with scissors. No way. No way. I had another therapist who thought they could just use a Dremel tool. Do you know what a Dremel tool is? The boys probably do, but the girls don't, right? It's like a little sandpapery thing that cuts through things, and it creates heat. You also cannot use that on this, all right? You have to have a cast saw. If you don't have one, can you work with the doctor that referred and bring her to their clinic and remove it? You know, but you really need a cast saw. Because sometimes you have to take it off and you didn't expect to, so you can't really make an appointment to go to the surgeon's office.
Can you repeat why we use plastic over what's the other thing?
Fiberglass. Because the plaster conforms to the hand better, like the palmar arch, and it just gives that proprioceptive feedback that the fiberglass does not. Because the fiberglass is more flat. This is very messy, and you don't want to wear black the day that you put these on. Because your pants are just gross, and if you see that person at 9, and then you have the whole day with white all over you, you know. But this works really, really well. Everyone that I've done this with has gotten better. But do you think your patient, after all this time of immobilization, is going to want to go back in a cast? No. So you have to kind of talk your patient into it. And you can't just cast them for the weekend and take it off, and it's got to be a prolonged time.
How long?
Yeah, a long time. It's different with everybody. It depends on how long the stiffness is, how bad it is, right? But usually at least 2 to 4 weeks.
Does it affect like what's good though when you take it off?
No.
Doesn't?
Not from my experience. The wrist might feel stiff a little bit, but then it gets moving, yeah.
So we were kind of comparing it to Constraint.
It's like Constraint induced, yeah, it's just like that. Yeah.
How do you know when to use this over a splinter?
So patients will like a splint way better because they can take it off and on. And these patients are all, they're outpatient. They're working, they got kids, they got to take care of their house, they got to cook, do laundry, clean, mow the grass, cut wood, all this stuff. And they can't do any of that with the darn cast on, right? So if I would do it earlier, maybe I would think that I would say casting, but I usually hold it out for the people that I can't get to work well with splinting. But if I would just bite the bullet and do the casting first, so I don't really know, because I save this for the toughies. But what if I just put all my proximal phalanx fractures in a cast to get them their hook fist for 2 weeks, and then took it off and started working on everything? You know, that's a good research project. You know, maybe Judith Kolditz would be interested in working with you on something like that. But it works. And you can't just take it away. You gotta bivalve it, strap it on with Velcro straps, wean it. If you just take it away, now I didn't do a research project about the mallet finger splint weaning, right?
Yeah,
But if you just take it away, they start to lose their hook. You gotta wean them from it. Wean them off the cast.
Cast to splint.
I cast for a period of time until I get a good hook in the cast. Once they get a good hook, I cut it with the cast saw, put Velcro straps on it, and so they can take it off and on, and I wean them from it and have them wear it all night. And I've tried even doing it, like I'll cast them, and then the cast is yucky. You know, so you don't wanna bivalve it and have a wear, so I've tried doing a splint then, and making a clamshell splint to replicate what the cast does, and it does not work as good. There's something about that cast with the padding, and I don't know what it is, the proprioceptive feedback they get that they don't get from a splint, I don't know. But this works, it works from my experience. But you have to be willing to leave it on.
Have you ever had patients that like just disregarded their hand altogether and just didn't use it ever?
My CRPS guy, absolutely. He disregarded his hands once he wouldn't wash it.
So in that case, would you just split? So
No, I don't want to split. I want to give their hand to experience the world. Putting them in this is like solitary confinement. What am I doing to my central nervous system when I put them in this? Decreasing the size, giving up my real estate, right? So it's always this balance, you know? That's why you always have to, like, you can't learn everything here. No matter if you were here another year, I mean, you all are leaving now, this is your last week. Even if you were here another year, you would not learn it all. It's a lifelong process of learning. I've learned from every patient I've treated. I've learned from everyone I've worked with. I've learned from doctors. I've learned from students I've had come with me for level 2. You learn all the time. You're never going to know it all. So you just have to get experience and practice and figure out when to try something, and you'll make mistakes. And then you will learn, right? Does someone have a question over here?
Did I miss, I think, why you said with the cast what works well and not cast what works bad?
It's like constraint induced. So you block. So if my fingers need to flex, I need to get a hook. So I'm going to block those MPs so they can't flex. I'm going to block the wrist so it can't flex.
Okay.
I'm going to immobilize everything that moves well. And there's something about being in this cast that makes you want to pull your fingers down. Yeah. And another thing you have to think about is cast claustrophobia. Have I talked about that in this class? Okay. So I went to this casting class, right? And we all had to cast each other, and then we went home, and then we were going to go back the next day, and she had saws, and we all were going to learn how to take off casts, right? So my partner casted me, and this was in Chicago. I remember my partner was Laura Clark. I'll never forget it. And I was like, I really want this cast off, you know, like. And then it got to the point where I'm like, I need this cast off right now. Like, I cannot go home. And then I was like clawing at the cast, trying to get it off. And then the teacher is like, I'm like, I have cast claustrophobia. I feel like I'm at a 10-step program or whatever. But I do. I knew I had claustrophobia because my friends tried to lock me in a trunk once at a drive-in movie to get me in free, and it was bad. Bad! Couldn't take it. I'm pounding at the trunk, and there's another girl in there with me. It was bad. Like, so I knew I had claustrophobia, and then my sister used to like hold me down where she would like sit on top of me and put her knees over my hands and poke me in the chest. And it was that whole thing of being held down. Like, I have this traumatic memory of that. But, so I have claustrophobia, and so putting in that cast, I couldn't take it. I had to have it taken off. I could not leave that cast on. So some of your patients also might have claustrophobia, and they might have cast claustrophobia, and they're going to come into you and they're going to say, this cast is driving me crazy. I can't sleep. I can't wait to get this thing off. How many more days do I have? Like, when you're hearing your patient say that kind of stuff, you have to think, there's literature out there about cast claustrophobia. It's a real thing. I didn't know about it when I went to this class. And since then, I have called physicians and I say, the patient is not tolerating a cast. Can the patient come in and cut it off? Just if you just cut it and put straps on to hold it on, they are fine. It's the idea that you can't get out of it. Like, I couldn't get out when my sister's laying on me, right? The trunk, you can't get out. It's that having that volitional, even though they won't take it off, but knowing they can take it off decreases the anxiety about that. So if you're hearing your patient say all that stuff, it's worth a phone call to the doctor and say, hey, do you think, I've heard of cast claustrophobia, or do you think we could, cut it and I could put Velcro straps on it to hold it on? Because it's a real thing.
Is that, so, you always screen your patients for claustrophobia then? Not
No.
in the trunk, but just
No.
ask them to know.
No, I don't bring it up. They'll bring it up.
They'll bring it up, okay.
If they are this problem, they'll tell you, I can't sleep, right? This cast is driving me crazy. It doesn't fit right. It's uncomfortable. It's bothering me here. It's like all these things are about the cast, right? And they could have cast claustrophobia. So, okay. So here, hook fist, right? We want the hook fist. And I can't remember if this was the girl with the ring. No, I can't remember who this was. It might have even been, I can't remember. And here's the hook fist, right? Another option out there is called the Digit Widget. The Digit Widget, okay? And this is a surgical procedure that we don't do, but you might treat people with a Digit Widget. And these are for patients that have huge stiffness and a lot of times in both planes of motion, in flexion and extension. So I had a patient once, this was long before the Digit Widget was invented, and she would have been the perfect candidate for a Digit Widget. She worked for an auto company in Toledo, and she had got her hand caught in a press. And she had fracture, tendon, wound of her ring and small finger, and just big time problems. And we would get her straightening, then she'd lose bending. We'd get her bending, she'd lose straightening. She could never keep them both at the same time. And eventually her work comp stopped paying for services because she had gone to therapy so long. And she was fused in this position. She had a hook fist. And she ended up getting an elective amputation at the PIP so she could at least grasp things without her fingers being in the way. But the Digit Widget has pins that go into the proximal phalanx, and then the rubber band pulls the joint and rests it in full extension. So you take the rubber band off, you work on blocking exercises to get the PIP to flex. You put the rubber band back on, and it pulls the joint back up into extension. So they're held in extension all the time with traction, rubber band traction, right? And then you remove it every hour to work on flexion, Digit Widget. If you work in a high-paced, dynamic hand center, you will likely see a Digit Widget. Like Dave, you'll probably see a Digit Widget. Andrew, you'll probably see a Digit Widget. I don't know where everybody else is going, but you'll likely see that. So this shows you, like, when they leave, I'm wrapping everything in Coban, because what am I trying to do with the Coban? Control the edema, because the edema is going to lay down more scar, right? So they have surgery where they release all the tendons, they release the joint, so everything's moving well. But if you don't do something, they'll lose it, because they're big scar makers, these people.
You said the pins go into the bone, right?
Yes.
So it's kind of similar to, like, the same concept as external fixation, that something's coming out.
It is. You're going to worry about pin site infections.
Wouldn't that be painful? I mean, if
It's
you're
painful.
on the pin.
It's painful. You have to have the right patient for this. You can't have a patient that's not very stoic.
And you bump that off.
Yeah, you don't want to bump it. No. So here it is with it off. I have a hard time seeing. So you can see the pins cross the PIP joint, right? But if I undo the rubber band, then I can work on PIP flexion, and then I put the rubber band back on, and it holds it back in extension. And they have to wear this for a long time, like 6 weeks, 4 to 6 weeks. So here's a picture of me taking off the rubber band. See, I unhook the rubber band, and then I can allow PIP flexion. And we work on flexion. Here he is making a fist, but should I work on fisting? Is that what I should do? No. What should I work on? Blocking. Blocking. I gotta get the MP up, get the intrinsic stretched out, work on isolated joint motion. And his DIP was not released, which I think was kind of an error because I could never get the darn thing to move. His DIP. So this guy was a military guy. You can see the camo, right? He was a military guy and he was stationed in Germany and had an injury and he went to therapy there, but he didn't get the right care. I think he had a fracture dislocation. And this was his right, it was his gun hand, whatever, right. People are challenged, I can't tell the right from the left, but it was his gun hand. And so he couldn't shoot well because the finger was like in the way of making a fist, you know? I don't shoot guns, but he couldn't shoot well. And so he couldn't be in active duty because of all that. So he was working at a recruiting office. So he decided to get the finger fixed. So the doctor opted to do the digit widget to try to get motion both directions because he was stuck in a hook when he came in for the because I was there for the consultation the first day he came in, really super stiff. So I'm working on blocking and look at my unstable thumb, by the way. Do I see a nice arch? No, right? But I'm working on blocking, trying to get the PIP to move. And here's his fist. Okay? So the digit widget is something else that might be out there. If you have one, put something on this Velcro while you're working with the patient, like just a piece of strapping, because it sticks to everything, your towels, your all this stuff, and then your patient's stuck to where you don't want them to be stuck. So put something over the Velcro when you take off the neoprene sleeve. So, okay, any questions about John? I mean, about, his name was not John, that's my next case. Any questions about the digit widget?
So he ended up, like, how was the outcome?
His outcome, I would say, was not perfect because I could never get the DIP to move. His DIP, it would have been great if that was released at the same time, but his PIP joint moved pretty well. He didn't have exactly full extension, but good flexion. But still problematic because we couldn't get the DIP to bend. Okay, but I've treated several people with the digit widget. If you're in a camp clinic, you'll like to see it. Okay, now here comes another case, and it's kind of a bad picture. Like the next picture is a little bit graphic, all right? So I'm going to end, I think this is the end, on like a case study of mine, which was a really frustrating moment where I almost like quit my job. I was so PO'd, right? So this is John. He had multiple injuries. He was another auto Ford and had his hand caught in a press. So he had fracture with wound and edema. So he had a crush injury with fracture. He had a delay in appropriate treatment because he saw an orthopedic general surgeon, and then he went to PT, and then he went to hand surgeon, and then he went to me. So he had a delay in appropriate treatment. So it also caused him to have multiple surgical interventions because the general orthopedic operated on him, went to PT, then the surgery had to be redone by the hand surgeon. And it was a work comp case, so think of the cost, right? He had great patient characteristics. He was very stoic, did everything I asked him to do. You know, great guy, all right? He didn't have any sympathetic symptoms that limited his treatment. No signs of complex regional pain syndrome, which was a good thing, right? And he didn't have any insurance limitations because he was work compensation, so I didn't have to worry about number of visits or co-pays. And they let him, when he did return to work, they let him leave work and come to therapy. So it was very, sometimes employers will let your patients do that, and sometimes they have to do it at the end of the workday, which makes it harder to get patients to come in. So here is the first day that I saw John. Okay? Here is the first day that I saw John. And I was angry. So what do you see?
There's macerated wound on his fingers.
His wounds are really macerated. here, all here. He had a fasciotomy for edema, so he has incisions down each side of his fingers that were purposely made to prevent constriction that would prevent blood flow and nerve function. So he had a fasciotomy by the surgeon to keep his hand dry, okay? What's that?
It was improperly dressed though because of the maceration.
Improperly dressed. So when I took the dressing off, can you see this adaptic?
Yeah.
They had a daptic in between the wounds, and then they had his hand all wrapped up in one big wad.
So with that, I mean, his fingers are like that. Are they sticking together?
Yeah.
Oh, that poor guy.
Yeah, he was all wrapped in one big swoop. Do you think he could move his fingers wrapped like that? No. Do you think his wounds drainage would be absorbed appropriately wrapped like that? No. The PT wrapped him like that. Okay? So, what else do you see? Huh? He has percutaneous pins, and that was conversation during the wound clinic, or wound class on Saturday. Some doctors still leave the pins out the skin, and some doctors said they don't, they cut it off at the skin. So these were, he had 4 metacarpal fractures, index through small finger, and he had percutaneous pins to stabilize the fracture. Okay? What do you think the PT was doing for treatment? No, not strengthening. It's not that bad. Or mobilized, joint mobilization. No. And I'm not knocking PT. I'm just saying PTs need to be trained appropriately to treat this kind of an injury. So when I saw this guy, I called the PT, and if I could have reached through the phone to wring his neck, I would have done it. I would have done it. And he worked for the same company that I worked for. So when I talked to him, I said, you know, what the heck? We work for the same company. Why didn't you refer the patient over to me? His response was that he's perfectly capable of treating upper extremity injuries. He's trained. This is how the patient looked, right? I said, if this was your mother or father, you know, would you have kept the patient or would you refer them to me? And he said, I would have kept the patient. Right? So, what happened is, the orthopedic surgeon treated the patient for metacarpal fractures, all right? The edema got so horrific, they called the hand surgeon in to do the fasciotomies. The patient went back to the hand surgeon, whose office was across the street from mine, and saw this patient, and the hand surgeon called me and he said, what the heck are you doing with my patient? Because when the patient told him where he was going to therapy, he thought I was treating him. Because why wouldn't the hand therapist be treating this patient? Right? So the doctor calls me, you gotta come over here right now and look at this patient. This is what I have. Right? I was so mad. Couldn't sleep for like days. I was so mad over it. But anyway, this patient was great. The hand surgeon took him back into the metacarpal fractures were not healing with this fixation. Okay? What happened was the case manager then sent the patient to the hand surgeon, who the doc went back in through this same incision site, which was created as a wound as part of the crush. Put plate fixation in all the metacarpals, and the patient ended up doing fine. But now this is a pretty drastic case. But what would you do with this patient first off? Clean the wounds. So what am I going to clean it with?
Saline.
Saline. Can I put this in the sink with water? No, because they have pins in. No. So I'm going to clean with saline. How am I going to dress the wound? Something that would absorb and something that would keep it from sticking. So I have to use adaptic, but I can't put a big wad in there like that. I just got to cut a little strip to put it over the open area. I cannot put adaptic on all of this macerated skin. No. I'm going to put the adaptic down. I'm going to cover it with an absorbent dressing. I have to wrap each individual finger separately, okay? And I have to get the edema under control because will the maceration and the wounds heal if I get the edema under? If I don't, they won't. I have to get the edema. So then I Coban wrapped each individual finger over the dressing and all the way up the hand to get the edema under control. And you'll be amazed at how quickly this can turn around if you just do the right things. Okay? If he did not get the right care, this would have all opened up to big giant wounds. I don't know what would have happened.
How did you think of the fingers apart?
You have to just pull them apart gently.
Oh, I thought the doctor might bring him in and just.
No.
Is there a point where you can like call the doctor and be like, I'm not comfortable separating fingers?
Will you get another patient from that doctor ever again? If you're going to do this, you got to do it. You can't pick. If you're going to do hand therapy, you have to do it. You can't pick, I'm not treating that patient.
But I think what she's asking is like ethically, if your patient is screaming and
Oh, yeah,
and
you
you are
can.
yanking their fingers apart, like, can you call the doctor and be like, my patient's gonna pass out? Do you have a suggestion?
But you know what you have to do? You have to use your therapeutic use of self, and you have to let your patient trust you and get through it. You have to get through it.
If there's no other options.
What are they going to do surgically? No. And the metacarpal, this, I mean, I could get in between the fingers. And you can be amazed, if you hold the dressing like this and slide it in, get the other one wrapped up, and then work on the other finger.
I guess a maceration is gonna come apart a lot easier than this.
Yeah. 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 You'll get some, you know, it depends on what environment you're in. If you're getting post-op patients, you have the potential to get stuff. If you're getting itises, then you likely won't. And if you're getting referrals from general orthopods and family docs, you're not gonna get this. If you're getting referrals from dynamic hand surgeons, you're gonna get. Well, hopefully you won't get this because they're hopefully more skilled surgeons. Yeah.
So if something as severe as this, they should always be referred to a hand therapist, correct?
What do you think?
I shadowed a hand therapist when I was getting into the program, and there was, I mean, I know they're all probably very different, but someone's hand got ran over by a Jeep, and that patient came in with their hand in a big ball wad like that.
Yeah.
What you're describing. So is that inappropriate then?
What do you mean a ball? A dress?
Like what you're saying, like they're, like that's why when you said that the patient came in with like this big wad, and that's why I was like, I don't even know what that is. And
Do they want it to move or not want it to move?
I don't know. I just feel like.
So if you don't want it to move, you're in an immobilization phase, and maybe they're working
They
on
took
their
it
shoulder.
off after, and it looks like it was just crushed like that. That's what I was saying, like the dressing was similar to what you said.
If you want it to move, you have to wrap the fingers individually. And if you have a lot of drainage in dressing, you have to wrap the fingers individually, otherwise it's just one buckle. Yeah. So it's hard for me to say, because I don't know the story.
Yeah, I
Like,
mean,
were they
it's different.
allowing the fingers to move or not? You know?
Yeah.
So the PT's answer was to just put the patient in whirlpool, have them exercise the fingers in the whirlpool, and put the dressing back on. Swear to God.
That'd be fine.
That's what the PT did. That's what the general orthopedic surgeon, that's what they ordered.
So,
Doctor Justin.
but if you got that from the general, you technically have to follow.
I would call I would call the doctor and I would say, the patient, I'm worried about putting a hand with pins in a whirlpool. I'm gonna take open invitation for infection and sink in and swirl all my dirty tissue around it. That maybe someone else's dirty tissue didn't get all the way cleaned out of there from the last time, you know? Yeah, the PT put the patient in the whirlpool, that was their treatment. So, and you wonder why it's macerated, right? Yeah.
In that case,
And bill them for it. Yeah.
would you contact the original surgeon and say, you can't do that?
I wouldn't. What's my benefit of doing that? The hand,
These patients, like, if they keep going to PTs and don't you?
I know.
I don't know.
Can the patient sue the PT, like,
Yeah,
right?
yeah.
Can you hint them to do?
No,
Even
I
if-
know. These are slippery slopes, you guys. No, you can't do that.
Can you say your doctor too much?
So what happened to the PT?
Nothing.
Nothing happened, he keeps on treating.
Yeah. He's in Toledo.
Was there a reason it got sent to him first though? Like, his insurance just kind of.
The orthopedic surgeon that's in the same building as the PT clinic, and the orthopedic surgeon sent the patient to PT.
Well, the meeting's over.
Right. Yeah.
Reflux.
Yeah. But we did all the right things. He had surgery which fixed his metacarpal fractures by the hand surgeon. We controlled his edema, and the end of story is that the patient ended up with full finger flexions. You can see his fasciotomy scars, right? Which nothing we can do about that. We got them all healed. We used silicone gel to control it. The next picture is a bad photo because it's yellow, but he had full extension. He still had this pretty significant scar, but it didn't really impact his function at all. He had full flexion, I mean, look at his flexion, it's beautiful, right? Full flexion, full extension. He went back to work, full duty, eventually. And it actually was surprising how quickly it went once he got fixed the correct way and the correct treatment. It didn't take that long because he had all good patient characteristics. He did everything we asked. He was very tolerant of everything. He was a really good patient. So the big, I said that was the one big take-home message, but if your patient is not progressing, you gotta change. And if you're doing something, you should be able to explain what you're trying to accomplish with it, not just because you had that treatment intervention in the cabinet, right? You have to be thinking about what you're trying to do and then figure out what you have to do to get there, not just what you have in the drawer. And the PTs will call them our toys. It drives me crazy. I just went to a meeting last week, Thursday, at Calvin Clinic, and the PT there called our therapeutic modalities toys. It drives me crazy. But do not just open the cabinet and look to see what you have to do with a patient. Think about what your patient needs and adapt that to what they need. If they're not getting better, you have to change it. You can't just keep doing 12 visits with no change in range of motion and keep doing the same thing. You got to figure out why they're not getting better. Okay. And I just, at the poster presentation on Thursday or Monday night, I was just talking to one of the therapists who graduated in 2011 and from here, and they still have their Facebook page, and they use it. And they use it to ask questions, to support one another. I have a patient, I've done this, and they're not getting any better. You're not saying their name, and you're not saying all their information, or even where you are working, or anything. And so I have a patient, distal radius fracture, they're complaining of ulnar side pain. What should I do? Someone from your cohort can respond. You can call Nancy. There's all kinds of things, but use each other. You have your cohort as a whole group of resources. Your front line of questions, right? So use that. But that's it. Oh, these are just pictures just showing different traumas, like you don't want to wear a ring, right? You do outdoor work. Had lots of degloving injuries from rings. Crush injury. These are all just hand traumas, and then this was a big piece, right? You don't want that. Catch it with your hand, right? But yeah. All right, so I'll see you guys next week, Wednesday at noon. If anybody wants to have their pinch checked, I have the pinch meters in the ADL room. We can come check your pinch. Okay, and then our cultural talk's at 12, so stick around for that.